I'm broadly interested in different aspects of long-term changes in mortality, fertility, but also migration. And some of the key questions that I've looked at is social inequalities in health and how, in different contexts, how they changed, both in fertility, but also in the mortality. And some maybe like, because it's part of the kind of database management course series, data that I've mostly worked with is longitudinal data sets, both using the English Parish Reconstitution data sets, but also longitudinal data for Estonia that we have for a few places. And I've also used a lot of large-scale census data and also some census-linked mortality data. So that's kind of my background. So could we maybe do a round that each of you tells me what's their background and what type of data sources you use, because then it helps me throughout the lecture maybe come back to it. Could I maybe start if I tell Mark, could you tell me a little bit about yourself?
Oh, I'm very dark, but
Oh, can see you now.
yeah, so I'm Mark. I'm currently working on my PhD at the University of Turku. And so I'm a evolutionary biologist officially, but I also delve in kind of like anthropology a little bit and human life history stuff a lot. And so I'm quite new into my PhD, like it's not even been a year yet, but I'm currently focusing on mostly historical death causes and looking at the spatial patterns that we see of historical death causes. So for that, I'm using nationwide records from Finland, spanning like from 1800 to 1850 mostly. And yeah, I'm actually kind of curious also about the social determinants that you were talking about, because I currently also have a master's student who wanted to look at some, well, socioeconomic status for certain death causes. But then we found out how tricky that is in such a historical period to really determine that. And yeah, so that's very interesting. But yeah, so currently I'm still kind of working on the historical death causes and translating them a lot. But yeah, that's kind of my topic. Thank you.
Great, thanks very much. That's good to know, and definitely things that we're gonna discuss today. So Vera, could you tell me something about you?
Hello. Yes,
Hi.
I'm also a PhD student in University of Turku, and I'm working with a very long-spanning data set on death causes in Finland. But my background is also that I'm an evolutionary biologist, and I'm interested in social networks and how these predict the death causes or have predicted them in different points in history.
Cool. Very interesting. Thanks very much. Carolina, you're next. I'm just going by the screen, the kind of order you are. Oh, Carolina, if you maybe can't speak, that's fine as well. Simone, can you go next maybe then? Ah, yeah, no worries, Carolina.
Yes. Hello. I'm PhD student at the Adam Mickiewicz University, and I'm working on the Poznań Historical Population Database, and the same source Karina is using, and we have long-spanning data on the deaths, marriages, and births in the 19th century Poznań. And my research area is social mobility, and to be more precise, how adverse conditions in daily life affect social mobility. So yes, we have like plenty of data in history of Poznań.
Yeah, very nice. Thank you. Udav?
Hi, it's
Hi.
good to see you again.
Oh,
Yeah.
good to see you.
Yeah,
Some
I'm
familiar
Siddharth.
faces I can see.
Yeah, Seema, yeah. I used to work on global health topics like cervical cancer, menstrual health, but I have started working on for the last 3 years. I started with 1918 influenza pandemic and the evolution of mental health in Norway, but now I'm mostly fixated in mortality inequality, how the mortality evolved throughout the period and different stressors, the big stressors like the pandemic, like the economic crisis, how these things affected the mortality. I don't have a PhD and I'm looking for a PhD. Yeah.
Thanks very much. Thanks for sharing. So Abel, you maybe missed the beginning, but we're just giving a background, like each other's background and what type of data sources we use. So Abel, if you could.
So what kind of data source I use currently?
Oh yeah, what are you more familiar and what's your background?
Okay, I'm sociologist economist in Hungary. Previously, I worked for 4 years at local research institute, but I started to work with associations of health and politics. Okay, deindustrialization, health and politics, you know, this death of despair and populist breakthrough and so on. And that's the reason why I'm interested in this health issues and social inequalities in health.
Mm-hmm.
And what I use, well, nowadays, mostly administrative, geographical data, and I made a huge database also with Eurostat NUTS2 level data and European Social Survey. So combining these two data sources. Yeah.
Okay, thanks very much. So we have a good mix here, like more maybe historical questions that you're looking into, but some also not more contemporary, and also looking at longitudinal data. We have some also looking at geographical data. So these are all some of the things I'm going to discuss today. It might be, of course, if you already read up quite a lot about social inequalities in health, this might be not new information for you. So sorry about that. And of course, this is all from very much from my perspective, because I'm historical demographer. I'm much more interested in kind of long run patterns of these changes or these differences. So that's where I'm coming. So if a public health person would give this talk, they would probably give it very differently, but bear with me. Or maybe this approach is even more interesting. So let me get started. One thing first to mention is when I'm talking about health inequalities throughout this lecture, I really use it as a synonym to mortality inequalities, because much of our research on like long run social inequalities or spatial inequalities uses mortality as the kind of health outcome. We've had very poor data on morbidity or health in the past, so that's why I'm using health inequalities, both meaning mortality inequalities. But that doesn't have to be the more contemporary or data sources become. So, of course, much of the literature can then focus also on health and morbidity in a wider sense. See if I can change the slides.
We cannot see your slides. You should present it again.
Oh, they went away again. Oh,
yeah, sorry.
Luckily, I hadn't changed anything, so. Now you can see?
Yes, we can see. Thank you very much.
Thanks, Emmer. So maybe to start off, what do we think, given what are health inequalities? How do we understand health inequalities in general? So in a way, like inequality suggests some sort of departure from the idea of equality. And, mathematically or very simply, we can think of inequalities just about differences, like differences in some sort of measure of mortality. But at the same time, the word inequality itself also has very compelling social overtones. So they are, if we think of health inequalities broadly, they are some kind of cause and consequence of the distribution of resources in different societies for different subgroups. And these kind of reflect how people live or lived their lives, how societies are organized, and also the distribution of resources within those societies. So you can think of this kind of diagram shows this kind of health differences. We can think of this kind of inevitable. There's something that we can't do. But the moment we think about that there's some avoidability or preventability, they're kind of socially produced inequalities then. And there's this kind of notion of unfairness about them. I think that it's important to make a distinction between equality and equity. And in a way, this diagram shows it, that equality is something that everybody has the same opportunities, whereas equity has a slightly different meaning, that individuals are then given different type of support, but opportunities to succeed to the similar kind of level. But I think a lot of the public health literature, and also I think in a more demographic literature, this kind of inequality and inequity are considered similar terms. In other words, they're both considered unjust, that health differences just are unfair and unjust. And so a lot of this kind of social inequalities literature, very social inequalities in mortality literature, broadly is interested in the social gradient in mortality or health. And this kind of stepwise, often linear decrease in health with decreasing social position, having a lower social position, meaning having a lower level of survivorship. So when we health inequalities exist because of social, economic, and environmental factors that influence these kind of opportunities, behavior, attitudes, and lifestyle are kind of different. And we think of this kind of the social determinants of health framework. You've probably seen this very famous, often called as a rainbow model. I've used the black and white, but it's always often also kind of rainbow colors. So in a way, these kind of social determinants of health are circumstances that people are born, grow up, live, work, age, and system put to place to deal with illnesses, health, or mortality outcomes. And this framework is the Dahlgren-Whitehead framework. It is a simplification to understand the various factors that influence health. So it's not only about people's individual's choice, but it's much more broader than that. It's about the social, economic, and environmental conditions. So in the core of the model, in the middle there, you see is kind of these individual factors. People have their own individual characteristics, so that's kind of the center of the model. But it's as important, the kind of surrounding layers that impact people's health. So there's the individual lifestyle factors. This could be smoking, diet, exercise, and those are very direct influences on people's health. You have the social and community networks. This is about social support, community norms, relationships, and that those can have positive or negative impacts on health. And then you have another a bit wider layer that then includes living and working conditions, about housing, employment. It's also general socioeconomic, cultural, and environmental. And this could be also about now wider society. So social policies, economic systems, cultural values, and also environmental conditions that then impact people's health. In a way, this provides a very powerful and widely used framework for understanding how social, economic, and environmental determinants influence health. And it really emphasizes the importance of addressing these factors to improve well-being or reduce health inequalities. So you can't just focus on one, because there's like a complex system of factors that influence people's health. So the start was very much thinking about broad concept of social determinants of health, and much more in a contemporary setting. But what I want to go through today is think a little bit about different types of measures of inequality. I won't go detailed showing you how to calculate different types of measure, but I just want to give you an introduction about them, and also to show some examples of studies, how they use this type of different measures. I want to discuss about different types of socioeconomic status and how we measure that. And of course, your own data sets will have different types of measures of socioeconomic status. So maybe we can kind of, throughout this lecture, kind of have a little discussions about who has what type of socioeconomic measures, and what are their kind of strengths and limitations. And then I want to finish on really talking about showing some examples, like theoretical frameworks, understanding long-run changes, and also thinking about showing you some examples of different types of studies. Most of the examples are historical or looking at long-run patterns. Sorry, there's going to be a lot of Sweden examples, and we all know why. But I'll also have some examples from more recent, let's say, papers from last 20 on mortality about last 20 years, 30 years. So kind of that's more contemporary for me. But yeah, let's get going. So life expectancy is, one of the key measures of population health. We're not going to talk about how to calculate life expectancy, but it really captures the kind of mortality along the entire life course, and is a very good measure to compare different countries or populations. So in a very broad sense, just comparison of life expectancies between countries is looking at mortality inequalities. So research actually more often focuses on between country inequalities than rather within country inequalities. We'll get to the within country inequalities in the later part of the lecture. But this just shows you, using some of the data from our World in Data, the increases in life expectancy for a few different type of countries. And what I really wanted to showcase here was, first of all, very different roots of historical roots of where life expectancy levels in different countries. So, for example, if you look at India, the life expectancy levels start from much more lower than, for example, the historical patterns for Sweden or United Kingdom that has a very long run time series as well. But there's quite a lot of variations, and definitely at different periods kind of stand out that may be to mention. So, for example, we have United States here, this kind of reddish color. And I think it's a good comparison if you look at the line for United Kingdom, which is the green line, and then the stagnation from around 1980s onwards that happens in United States, kind of I think somebody was interested in this deaths of despair type of literature. So kind of stagnation of mortality in the United States, midlife mortality crisis. That means this kind of very comparable level wealth and resources in United Kingdom and US, but having a very divergent patterns in life expectancy, so mortality outcomes. I've also added Estonia on this graph, kind of a place I study, but it also shows nicely these kind of stagnations that happened during the Soviet period. And this line is very similar for most Eastern European countries, these kind of stagnations from 1960s up to 1980s, also having a dip there, but then constant increases from the 1990s onwards for Estonia. Not all Eastern European countries have this kind of narrowing of the gap by the later period. So this is kind of very broad comparison of inequalities in mortality between countries. But of course, there's a lot of different type of measures of health inequalities that are being used in different type of studies. So here listed or diagram or presented on a diagram are a selection of commonly used measures. While there isn't really a straightforward answer to which measure is most appropriate, it's important to think about some of the kind of advantages or disadvantages of each type of measure. And it might be useful also in some cases to use multiple types of measures. So if you're interested in more measuring the distribution of health in a population, thinking about more this kind of Gini index type measures, which are usually used to look at variation or distribution of income within a population. Similar measures can be also estimated using mortality data. It's possible to also look at lifespan variation, and I'll show some studies using this measure to look at how distribution of lifespan variations by population subgroups might have slightly different trends when comparing it to just trends in life expectancy. So the second part is kind of measures of association is more so that the measuring distribution of health in population measures we could also think of some of them as more like measures you would use if you have much more aggregate data sources. Measures of association are also meaningful when using longitudinal, so when you have individual level data sources. So for example, you have an individual level cause of death, mortality register, and in that case, estimating relative risks, odds ratios, maybe in a survival model setting, giving you a regression coefficient to compare inequalities by different socioeconomic status measures might be more meaningful rather than having just an aggregate measure of mortality rate. You can also use frequency ratios, Pearson correlations of coefficients. There's also quite a lot of public health literature looking at these kind of indices based on ranking of the socioeconomic variables. So there's a slope and relative indices of inequality. And I'll have some examples how these type of measures are being used in the studies. So with all of these measures, all of them can be also further split into absolute and relative measures. And absolute measures describe the size of the difference, and relative measures kind of show the proportional differences between groups. And it's usually a good practice within health inequality literature to calculate both and report both in your studies. And why is it important? So here is an example from a study by Warren and Hernandez from 2007, where they were interested about socioeconomic inequalities and mortality in the United States over the course of the 20th century. So they have here data from the 1910 census, so the IPOMS data for US, that has some child mortality information. So they've calculated indirect measures of child mortality. And they also have data from current population surveys from the 1985, 1990, and 1995, where they can similarly calculate child mortality estimates for these different socioeconomic groups. So they separate out white collar, skilled blue collar, service, and unskilled farm. And it has two different panels. So on the left side, you have the absolute differences. So the absolute change in child mortality over this period. And what we really easily see is there has been a huge improvement in overall improvement in child mortality over time, but also social class or social, this SCS group, and this has happened for all SCS groups. So child mortality by 1985 to 1995 is much lower. But you really should focus on the right side panel, which is much more about the relative risks of these different groups. So there, the authors compute the relative risk of dying before the age of 5 for the skilled blue collar, the service, unskilled farm, but compared to the class of white collar group. And what we see is, yes, by 1990s, the relative risks are lower, but the inequalities or the differences between social groups haven't declined actually that much. The only difference is for the service. That's actually service where they have, by 1990s, a lower mortality risk compared to white collar. But in a way, this is maybe a question about the measurement of socioeconomic status and what it means to be in a service sector in 1910 compared to 1990s. Just the jobs, the people who do these jobs, the whole social makeup of the group has changed over the time. So in any case, the general pattern of this study was showing that there were modest declines in the inequalities or the relative inequalities in SCS disparities in child mortality, whereas there were large decline in absolute levels over this time period. So having these two different aspects helps you kind of understand the process in much more detail. And throughout the lecture, I'll show a few, when I show other examples, it's maybe good for you to think as well. Am I showing you an absolute measure or am I showing you a relative measure? Because I'm not always showing both of them. So something to think about. So let's move on. And the next section, what I want to spend some time on is really about how do we measure socioeconomic status. And so socioeconomic status can be also called sometimes the social class, social stratification, or socioeconomic position. And these are often used interchangeably. So they slightly have different theoretical bases and interpretations, but depending on papers, depending on authors, they might use like slightly different forms of these statements. So there isn't really like single best indicator of socioeconomic status. It's all about the suitability of your study, the availability of measures often for us who are interested in historical data sources, and also the applicability at all time points, or if you want to change over time, like what is the best measure. So each type of indicator often measures a very different but often related aspect of socioeconomic stratification, and might have different relationship to health or mortality outcomes that you're interested in. So one of the aspects that I think is very important to consider is your measure or the type of stratification scheme you're going to use the best placed to kind of show the theoretical background to your interest in the kind of health inequalities. So let's move to the first. I really recommend for you to have a look at this Galobardes et al. 2006 paper, and there's Irmoelos 2009 paper, which super nicely summarizes different ways we can measure socioeconomic status, but also provides a lot of examples of papers that have used different types of measures. I'll start out with occupation, social class, because I feel that's probably one measure that we all have some access in our data set. Am I right? Can you raise hands who has occupation in their data that they've been using? Yes, Mark. Okay, Mark has occupation. Maybe, no, Simon as well. Okay, good. So different, there's of course occupations in the data, but occupational stratification schemes measure particular aspects of different socioeconomic status. What we can think of, what influence or what mechanisms influence health outcomes is, first of all, occupation generally is very strongly related to income, and through income association to health. So it's a measure of material resources. But occupation can also reflect the social standing of a person or the family, and through that social standing, health outcomes can be benefit out of privileges or not having, or cannot benefit if there are no privileges. But some of the privileges that could be like easier access to healthcare or services. It could also reflect people's social networks, but it also could be about occupational hazards or like reflect dangerous working environments. Thinking about the miners who this might influence directly their health and mortality outcomes. So how do we measure occupation? There's a very different types of approaches. You could use the current occupation if you have it in the survey data, census data. If you have a longitudinal data set, you could use the longest held occupation. So if you have many observations of the same occupation, you could choose the one that's been observed, because of course it's not a static measure. People can have different occupations throughout their lifetime, and have some occupation that you might have when you're very young might be, you might have a higher status job later in your life. So kind of it's not static. But you could measure it also for the whole family. So it doesn't need to be an individual measure. It could be a household level measure. And that's often very common in historical research, the head of household. And there are different classification schemes, and I'll come back to those that are more relevant for historical research. So what are the strengths of occupational? So what I can think of, one of the main strengths is availability. Pretty much most data sources will have some information about occupation, especially when we think of this kind of data that might also have health information. So very early on, parish death registers start recording parental occupations or male occupations. The censuses always have occupations surveys collect on every occupation. So the data that we have probably on occupation is one of the best, and that's one of the reasons probably why a lot of the studies, especially looking at long run, will use some sort of occupational classification scheme. But with all of these measures, there's always some limitations. So with occupations, what I can think of is that there's not everybody's working. So how do you classify these people? Do you classify them as a group? One option is classify the group, for example, like married women might not have occupations in the earlier periods. You could use the head of the household or the spouse's occupation. But yes, in different periods, these inactive populations or people out of labor force populations can be very large. So it's something to think about, and the composition might change over time. Who is the inactive population? And these compositional changes are important straight away when you're trying to use occupational or social class measures over time, because meaning of occupation changes over time. So the large share of people working in agriculture, so agriculture workers in late 19th century compared to late 20th century is a very different type of group, different type of social standing. And of course, the comparability. Can we compare the same occupations across different contexts, and can the meaning change? So one of the most well-known, you might be also using this, is the historical international standard classification of occupation, HISCO, and different type of occupational or classification schemes, extensions of HISCO. So HISCO itself divides occupation into eight major groups and 83 minor groups. And altogether, I think there's almost 2,000 different occupational categories. What makes HISCO nice is that it's an international classification scheme, so it's relatively easy to put different type of occupation in different settings into the similar classification scheme. And that has meant it's been used often to comparative studies. But also makes it much more easier for us to compare studies that might just focus on one place, but if they use a similar classification scheme. And HISCO, so this figure on the right here is from, I don't know how to say it, Sedeman's dissertation paper, where he compared different type of the classifications groups. But you have the HISCO codes below. So you would have a different type of occupations coded between 1,000 to 99,000 something, and kind of having there's a certain gradient through this. So what I would say is much more used than just the HISCO codes are the HIS class, which started out being a 12 classes scheme. And there's a smaller version of 7 class. So it goes up from higher managers to unskilled workers and everybody in between. So everybody's in these different classes. You can see that if you look at the 7 class system, that the class number 4 has only few occupations in it. So it's very I think it's farmers because of the, so this is the size of the circle shows number of rooms. So this is from marriage register. So a lot of rooms are from that one occupation. But I think the 7 class version is the only one. I've also seen people using a 5 class version that even more aggregates these different occupations and classes them up. or even 6. So people use it in different ways. So then there's a social power scheme, SOCPO. This is something I haven't used myself in any, but it's more about social power, so economic or cultural power. So the highest social power is the class 5. So this is on this corner. So these are the 5. So this is the highest level. It's number 5. And then these are high commanders, macro scale, self-employed, and non-manual, super skilled people. Also the nobility. And the lowest level is, again, the unskilled workers. So we have this number 1 is then the lowest end. And then there's also a HISCAM classification scheme. And that one is a continuous measure. So that why some people use that is the kind of that you can, in your models or regressions, can use a continuous measure, which sometimes can be more useful. And this is occupational stratification scale, and it's similar to kind of CAMSIS scaling, if you're familiar on that, and it's an extension of this Cambridge social interaction and stratification scale. And the closer different occupations are on this HISCAM scale means these occupations are more related in terms of social standing and social networks, and how this scheme was estimated. This is more about the interaction. So, for example, in marriage registers, people marrying from a similar social background, similar occupational classes, and that's how different occupational codes have this kind of relationship. I think one of the important, and I think this figure shows you that well, is that all these different occupational classifications are slightly different. So they put occupations in different groupings. So whenever you use one of these classification systems, you're making a very strong choice about why using that. So I think it's always good to have some reflection about what it means and how your results, for example, if you're interested in social inequalities in health, would all these different classification systems show gradients in mortality, or are your results only indicating social inequalities in health using one of these? So it's always good. I believe it's always good to have different comparisons. I have an example of also, so this is using occupational classification scheme that's more contemporary. So this is from a paper by Katikreddy, and it looks at patterns of mortality by occupation in Scotland and in England and Wales, and comparing that. So they use people aged, both men and women aged 20 to 59, and they use a census-linked death record. So they have a census record and they have linked mortality records on it, so to get information about people's occupations. And they have grouped occupations into this kind of higher managerial, intermediate, routine, and no occupations. So here we see that this is a mortality rate per 100,000 person years. Is that an absolute or a relative measure of inequalities? If it's
a relative.
Relative to what?
Okay, maybe it's more like okay, yeah, I'm not so sure.
Yeah, it's a good point. Like, just good to think about it as well. So I would say usually when we compare population subgroup mortality rates, it's an absolute measure. So it's just the mortality rate for different population groups, absolute. in order to be relative, it should be relative to one group. For example, comparing higher managerial groups to the other, and you want to see change over time. So one of the absolute measures, and what it's showing is that the patterns for men and women are slightly different. So there's more overlap between, first of all, maybe the diagonal line means that if all these dots would follow the diagonal line, it would mean the mortality rates for these different groups in England, Wales, and Scotland are the same. But it doesn't really, especially for men, we see that consistently Scottish mortality rates are slightly higher for all occupational groups. And we need that these kind of lower occupational groups, the routine occupations, have much higher mortality rates in Scotland compared to England and Wales. And there's quite a distinctive pattern. So higher managerial have the lowest mortality rates, both in England, Wales, and Scotland for men. And then there's kind of seems to be a gradient, occupational gradient throughout. Whereas for women, the pattern is not so clear. There's much more overlap between different groups. And also the Scottish mortality rates are not so much higher compared to England and Wales. So I think those are main takeaway points. So that's one of ways to kind of show with your data differences by socioeconomic group using occupational data. And let's move on. Education. So education is interesting because I think this is the preferred measure of socioeconomic status in a lot of public health literature and in contemporary studies. Why do you think that is? What is something good about education? Yeah, Mark, you want to say something?
Yeah, maybe because it reflects more clearly an individual's kind of level or status, as opposed to, say, like a socioeconomic status of the parent or of the husband or something that is often used. Yeah,
that's definitely one. And it's one of the better indicators that always or most often exhibit significant association with measures of health. And some of these might be like to do with kind of human capital ideas, health literacy, healthy behaviors that education transfers. What about measurement way? What is one of the strengths of education?
I guess you have records or like diplomas possibly available of people who completed this education. And this way you can have like a easy access database of education in a certain area.
Yeah, true. We have, and definitely like education is widely available, but when thinking about going back historically, prior to very large educational expansions, for example, 19th century, we maybe don't have that much information about education. So one thing, what I'm thinking is really the stability, is that by early adulthood, people will have their maximum level of education. And that means that doesn't change over their life course. So that is a neat way of measuring kind of human capital, but it's like, by age 25, most people have finished their kind of educational trajectories. So that's one of the kind of why also in a lot of the public health literature, education is one of the main indicators used. So what education does, it tells us something about their socioeconomic standing. As I mentioned, it enhances people's human capital, health-seeking behaviors, ability to obtain, but also effectively use health-related information. So, for example, good examples are changing behavior of more higher educated people in response to public health campaigns. So and that can cause health inequalities if certain groups start to have a healthier behavior about something. So it's kind of positive health behaviors, positive health, healthy lifestyles. But of course, education also has an influence of our occupational trajectories, but also earnings. So it's also about material resource and how those influence health. There's also influences about psychosocial factors. So having a benefit, higher educated, maybe much more resilient to stress, and how stress-related negative effects on health might impact health inequalities. So coming back to the measurement, completed education is a good measure because it's early on in people's life course, and it doesn't usually change then after a certain time point. Education can be used both as a continuous estimate, like a years of education, but also often as a categorical. So having a low education, medium level education, high education, or different types of like tertiary education, high school education, different type of categorical variables can be used. It's also not only about your own education, but a parental education. So influencing your own later educational attainment, human capital, and then health, but maybe your own health early in life. And I also added here literacy, because of course, prior to mid-20th century, or definitely 19th century, a much more readily available education-related information is literacy. I think one of the main limitations with educational variables that historically it's very difficult to use. There's very little information, or when you have information, there might be not too much variation within population. Most people had low levels of education. Also the compositional changes, so different levels of education might mean different things across time. So something to bear in mind when looking at long-run changes. So the quality of education means that having a high school degree in one country doesn't mean the same as having a high school degree in another country. Maybe much more likely today, but maybe 50 years ago, it might have had slightly different meanings. And that kind of comes back to the comparability aspect as well. Thinking about, can we compare educational measures, like does 7 years of education in each European country mean the same thing? So there's no clear answer to that. So I've tried to, in a lot of these different socioeconomic status slides, I tried to put down quite a lot of some of the things I feel are important or were mentioned also in some of these articles, but you're more than welcome, and you should also think about some of these aspects that are important for your own work, or how you could use that could add on to this list. So here's an example of public health classic. This is Mackenbach's 2008 paper looking at socioeconomic inequalities in health in 22 European countries. So this is kind of a classic paper. I can't ask you if it's an absolute or relative measure, because it does tell relative index of inequality. So it is a relative measure. So what they do in this paper is that they use for 22 European countries census-based mortality estimates. So they have censuses, again, linked with mortality statistics for the period around 1919 to 2000, but not all this countries have exactly the same time frame, so they have slightly different time frames. But they have data on mortality according to age, sex, cause of death, and indicators of socioeconomic status from mortality registers. And I'm just showing you one example here, which is like educational differences in mortality for men. And how they characterized education, they used a categorical variable again, where it was the lowest level was no education or primary education. Then they had a lower secondary education, higher secondary education, and tertiary education, so kind of different categories. And they estimated these relative index of inequality. And as I mentioned, this is a very common measure in public health literature, so it's a regression-based measure. And it is the ratio between the mortality prevalence among persons at the lowest level of education compared to the mortality levels at the highest level of education. So then you get these measures. And they use this, they calculated these using Poisson regression models. And they also have a little confidence intervals on top. So depending on the size of the samples, it's slightly different. So as you can see, in all of these countries, the relative index of inequality is greater than 1. And this indicates that throughout Europe, in this period, mortality was always higher amongst those with less education. But as you can see, the magnitude varies between different countries. For example, if we find Sweden here, Sweden is here, always good to use as an example. So it's less than 2, indicating that the mortality among those with the least education was twice that among those with the most education. So we have here Hungary, Czech Republic, Poland, where this relative index of inequality is 4. So indicating that the mortality between the least educated and most educated differs by a factor of more than 4. And the smallest differences are actually in Spain, in Basque Country, but also very small in Madrid, Barcelona, and also in Italy. But Eastern and also Baltics have a much higher compared to the other regions of Europe. So a little example of how to look at educational differences in mortality. So the next measure is income or wealth. So we have talked about occupation, we have talked about education, and now income. It is a very good measure in a way to use your study because it influences health through a direct effect of material resourcing. You have having higher level income, better quality resources, both food, but also housing, better access to services, kind of social standing, and kind of socioeconomic position. But it is much more used in US studies than European studies. And one of the reasons for that is kind of the availability of income information is not as readily available in most countries. There's also willingness to disclose this type of information. So, for example, US censuses have information about income going back even into historical censuses, whereas I think in UK censuses, they still don't ask it, or they only recently asked something and it's very categorized. So there's just like culturally, it's not something you talk about, not something you mention in surveys. So it's harder to get that type of information. And there's different ways, again, to measure it. So you have the absolute income, like the net income, gross income. But it's important about the household income. So it's not just individual income that might matter in health inequalities, but the household level income levels. And there's also different relative measures of income. So indicators, for example, establishing levels of poverty. You can measure it some kind of percentage above the mean or below the official poverty level. So kind of using these kind of relative measures of income. I have an example here. So this is it's not actually a research study, like a paper, but this is from a Financial Times data journalist, John Murdoch, who does very cool uses similar data sources that we might use and do very nice visualizations of these patterns and kind of reporting for the Financial Times. And here he's showcasing the income and mortality differentials in England and US. And they used a study from, I think it's relatively recent, so it's 2019 or 2020 relative, just showing how at all different income levels. So on the left side, we have the distribution of income, so the bottom 1% to top 1%, and we have different geographical areas by level of income and life expectancy. And we see in England has higher levels of life expectancy at all levels of the average income. And only in the latter part does so the top 1% gets closer. Top 1% in US gets closer to England only in life expectancy. And life expectancy, as he mentions here, falls very steeply for the bottom 1% in US. And on the right side, you see the difference in the variation in the income. So there's very different levels of incomes in US compared to England, which is much more between 30 and let's say 100 and average 110,000 tall. I think it's dollars there. Whereas in US, you have many places where the average income levels are much lower or much higher. And there's almost a 5-year gap in life expectancy at same levels of income between England and US. So kind of telling you something about different inequalities between different countries, but also inequalities within income distributions of different countries. But yes, have a look at John Murdoch's work. He has very nice visualizations also about different aspects of life expectancy comparisons. And the last measure, of course, that's not the last measure that you can use to measure socioeconomic status, but one that I also wanted to highlight is the housing. Is an indicator of socioeconomic circumstances and has a direct effect through living conditions, but also it shows you something about material resources and indicator of wealth. So how do you measure housing or housing differences? There's many ways of doing it. So in more contemporary surveys, it's the household tenure. Do you own a house? Do you rent a house? That could be used as a kind of variable. You can also use household amenities. So for example, what type of water supply, toilet, do you have an inside toilet or outside toilet, for example, in a historical setting? Do you have plumbing, like, do you have a sewage connected to your house? And it could also about like household conditions, having how many rooms do you have? What is the house built of? Kind of that type of questions. And also measures of overcrowding that are very common, especially in historical research. Something telling you something about deprivation levels or something like that. And usually there's always some sort of housing information in different types of sources, so surveys, censuses, but for example, with historical data, if we're thinking about parish records, you rarely have information about housing in those type of sources. So again, historically might be more difficult to have access, except censuses, and also you also always have questions about comparability. Does the same measure mean the same thing in different time period contexts, so on, so on. And I'll give you one example of looking at mortality inequalities by different housing amenities is one of my own papers where I looked at water supply and its effect on infant mortality. And I also, so this one study uses data from Tartu in Estonia, where we have a individual level census from 1897, where we linked mortality data from parish death registers to the census. So we can follow up people from the census for a few years. And the census provides amazing information about the housing conditions. So we know the water supply, but we also know if the toilet was in-house in the yard, did it have any cesspits or type of sanitation? Was the yard paved or not? The size of the household. And we were interested to look at the impact on water supply on infant mortality outcomes, and also explored this through cause of deaths, because we find in a general model that water supply, yes, having water from artesian well and groundwater wells meant you had much lower infant mortality in those households than compared to households that were using the local river as the main source of water supply. And we see that this effect really works through the diseases of digestive system. That kind of is a very reasonable outcome, especially thinking of diarrheal diseases, that poor quality of water might influence. And at the time, the city didn't have any public water supply, so it was all groundwater wells or the very deep artesian wells that were the better quality of water compared to the quite a considerable number of households that used water from the river. But one of the ways kind of to compare health inequalities by housing conditions. So I think that came up through discussing all these different type of measures, is also that when do you measure them might matter, and the life course aspect of measuring socioeconomic status is something to consider. So in childhood, parents' education, parents' occupation might be meaningful, but that might also be meaningful if you're interested in long-term impacts of early life conditions. By young adulthood, you'll have a measure of education, but also these kind of through professional life, there's a lot of changes and a lot of different types of socioeconomic measures you can use in your studies. And measures you get from older people might be more to do with household income, wealth, but also kind of thinking about asset transfers. So quite a lot of studies using probate inventories or wills to estimate people's social standing in later life. And here's an example that really highlights that you can use different types of measures of socioeconomic status in one study, and they all might give you slightly different aspects of changes over time. So this study uses data for Finland and we have lots of Finnish people here, so from 1971, 75 to 2011 and 14. And they looked at 3 different aspects. So they looked at education, occupational class, and they also use data on income. So having a different quantiles. And occupational classes, they use a 3-class comparison, also with education. So they have estimates for life expectancy, showing that over time, life expectancy increases in all different educational levels. But it seems over time, there's a bit of a widening of the gap between the high and the low. The occupational class life expectancy grows in similar directions, and similarly, by income increases, there's maybe a stagnation for the second quintile compared to others, but otherwise moving upwards. But in that study, Alison van Raalte also uses lifespan variation measure, and this is one of the measures looking at the distribution of health inequalities within a population. And I think very simply, lifespan variation is the variability in ages at death around average. And this can be a supplement measure to look at the average longevity. So what we see is there's this changing relationship. Life expectancy is improving for all different occupational, educational, income quantiles. But the lifespan variation maybe reveals a more worrying pattern, that the less advantaged groups were not only dying early, and we see their life expectancy were lower, but they were also faced a greater, they have 12 years of lifespan variation in the 70s, but by the later period, it's increased to 14, whereas it's constantly improving for that. So the variability of death, ages at death, is improving for the high groups. So there's kind of this like double burden of inequality for the lower socioeconomic groups. And that has increased over time. And we see it both for occupational class and also the income quantile. And this phenomenon here showcases data for Finland, but studies have also shown it in other contexts. So this kind of lifespan variation for the low socioeconomic groups is actually increasing also in other places. And this is a lot to do with midlife mortality crisis and increasing the variation in ages of death. But let's move on. Talked about the measures. I'll go now into a bit more about thinking about the long-run changes of social inequalities in health and provide some examples. I just wanted to kind of show that, social inequalities in health is not some sort of a recent interest. It has quite a long-standing history. So one of the earliest, England and Wales has always, or England or UK has always been in the forefront of studying social inequalities in health and mortality. And the Registrar General started already collecting mortality by occupational class from 1850s onwards. And by 1911, they had their own very defined social class system that they were using that ranged from social class 1, this kind of higher professionals, higher managerial occupation, to social class 5, which is unskilled occupation. And it also separated out some specific occupations like textiles, mining, this kind of very specific, that had specific demographic outcomes. But also, France had early, they looked at the area level mortality differences and poverty from 1820s onwards, and from occupational differences. Studies on occupational differences in mortality start from 19th century as well. And USA, for example, has a much later history in studying social inequalities and mortality and social class differentials from the late 19th century. But there's been more focus on racial differences in mortality, and those start early 20th century. So different aspects of inequalities. So how to understand long-term changes in social inequalities. There's 2 or maybe 3 2-in-1 extension theoretical views on long-term changes. There's the divergence-convergence hypothesis by Antonovsky, and then there's a fundamental cause theory, or often called also as a constancy hypothesis. And there's a slight extension from the fundamental cause theory that brings in cause-specific mortality, which I think is quite relevant also in this Great Leap project. And all of these, I would say, are framed very similarly in this kind of demographic transition, epidemiological transition framework. So if we look at the divergence-convergence hypothesis, Antonovsky really argues that there are periods of divergences and convergences. So there's some sort of a diffusion of information about health interventions. And those periods bring about periods of convergences. So when, if in early period, only certain population subgroups benefit, when there's a diffusion of that information to other population subgroups, the convergence comes about. And also that when mortality rates are extremely high, so thinking about prior to demographic transition, class differences or social inequalities in mortality tend to be low, but also when mortality rates are very low, so kind of after transition period. And his periodization splits out this kind of before 1650 to 1850, and 1850 to 1970. So very early on, we have small SES differences. Diseases are highly virulent, highly infectious diseases, and there's lack of treatment. So everybody similarly, mortality rates are similar to all social classes. He puts the second period, so 1550 to 1850, as widening of SES differences and increasing of economic inequalities. So he says by this period you should observe in populations social inequalities in mortality. And at lower levels of mortality, Antonovsky's argument is you should have there's diminishing of economic inequalities, diffusion of sanitation and medical technologies, so means again narrowing of SES differences. And use different empirical papers to kind of showcase this periodization. In comparison, the fundamental cause theory argues that mechanisms of social inequalities change over time. However, inequalities itself persist. So that we should see social inequalities any time period. And Lincoln Phelan, who came up with this theoretical framework, are sociologists, and I think the early formulations of this theory, they didn't think much earlier than 20th century. So their long-term thinking probably mostly focused on 20th century. But in later formulations, they're a little bit thought a bit more about. So based on this fundamental cause theory, otherwise we would expect social inequalities in health to be observable across all time, across all space, which of course some of the empirical studies have not shown, especially prior to 19th century or earlier. So the extension, as I mentioned, from this fundamental cause theory is these kind of different stages of social inequalities, but taking a cause-specific approach. So each cause of death going through these different stages, you know, in a way, their own demographic transition. So you will have early on this kind of natural mortality stage where the cause of death are not well understood. There's no preventability. And in that time, you can see that these kind of social inequalities in mortality can't be large. But in the second phase, where we have the producing inequality phase, new knowledge about disease transmission, preventability becomes available. And that's the period when social inequalities start to rise, because just some population subgroups have access to information earlier. They change their behaviors earlier than others. From the producing inequality, you end up in a reducing inequality stage again, when this kind of health beneficial innovation, health behaviors, medical care becomes much more universally accessible and evenly distributed. And you should expect them to have also lower narrowing of social inequalities in health. And then you have the kind of disease death. So the cause of death is kind of so low levels that this is not very virulent and not very prevalent anymore. So there's kind of the health prevention is universal, and there's no more gains to be made. That's of course the most desirable outcome, but it's not probably also the hardest to reach, and not many. We can't think of many diseases that are in that phase really. So I would say, in summary of all these different, so thinking about the convergence divergence ideas, thinking of the fundamental cause theory, and also these stages of social inequalities, social gradients in the past, based on these theories, you would expect there to be, at least from the 19th century onwards, if not earlier, some kind of indication of social inequalities in health. So despite the weight of theory, there's actually quite a mixed bag of evidence looking at social inequalities in health. We don't see in every context social inequalities. So for example, there's this new paper by De Haro. I don't know if you've seen that, but it summarizes, it's like a meta-analysis of all different papers that have looked at social inequalities in mortality from 1790 to 1980. And sorry, the figure has not very good, I don't know if you can even see it, but here you have 1790 up to 1970 or 1980, so very long time span of different studies. Each row is a different study, and we have we have Southern Europe, Western Europe, and Northern Europe. And the green lines would mean it's a study period and there's no SES gradient in mortality, and the red means yes, there is a SES gradient. So there's interesting patterns here, that most studies on Southern Europe throughout these different periods have shown socioeconomic gradients in mortality. In Western Europe, there are mixed results. There is some examples. I think that's one of my papers actually showing some gradient but then you have other papers that show no gradients. For example, here, a lot of the Netherlands papers, but then you have a Netherlands gradient that shows a gradient as well. So depending on a question, depending on what type of measures you're using, the gradients are slightly different. And in Northern Europe, which is mostly Sweden, there's 2 studies on Norway, it's more, I would say, a classic pattern that we all know of, that there are no gradients in SES inequalities until kind of the 1940s onwards, when you see the emergence. But that showcases the kind of variation that you have in different contexts in these studies. I'll show some examples. of different papers that have looked at over time changes in inequalities in health. And I have 3 studies which are all based on Sweden, because annoyingly there are not that many places where we have good enough data. So here we have a study on inequalities in childhood mortality using, again, this kind of occupational classification scheme. And we have a mortality rate under 5 deaths per 1,000, which is a absolute measure of inequalities then. And they use data from the Socioeconomic demographic database that some of you have used in the summer course, if you took part in the summer course. 5 parishes, and from 1922 they have Landskrona, the town, included in the sample as well, so there's an urban population as well. And it's a longitudinal data set, and everything is coded similarly. Let me go back. And this is data for 50,000 children, and the SES measure that they use is measured by the head of the household, usually the father, but doesn't have to be. And what we see here is that up to early on, the social inequalities in mortality were fairly equal, but later, and especially in the beginning of the 20th century, there were some differing patterns. So, for example, we see here that by early 20th century, the farmers had much lower child mortality rates compared to other social groups. And we start to see also this kind of gradient. So unskilled workers having the highest mortality, and through the social class gradient, lowering of mortality, with a little standout by the farmers. But the gradient is very clear also from 1940s onwards. So this kind of gradient emerges during the 20th century. If we look at the adult mortality in the same population, so here example of a Bengtsson, Driva, and Helgaard's study from 2020, where they used these relative risks now from survival models. So this looks at adult mortality 30 to 59 by social class for both men and women, and it looks by period. So we can look at change over time in these social class differences in mortality. So for men, it's their own occupation, whereas for women, it's their... Oh, actually, in this study, no, sorry, it's not actually. It's also always the highest household occupation, both for men and women, which for men most likely is that it is their own occupation, but for women that probably is their spouse or somebody else in the household. And so how to read this table is that we have all these measures are relative to lower skilled. So if there's a higher value, for example, unskilled, that means they are 50% higher mortality risk in adult mortality compared to lower skilled. Whereas if you have a lower value than 1, that means you have a lower risk. And some of the takeaway messages from here is that this kind of social gradient for men becomes more evident by 1970s only, so there isn't any clear social gradients prior to that, and slightly earlier for women. So, for example, if we look at the 1950s, high white collar women in high white collar families had 40% lower mortality than lower skilled, and lower white collar had 20% lower mortality compared to lower skilled. So this kind of gradient becomes stronger from that period onwards. But this is very different than some of the studies for Southern Europe, where earlier studies show social gradients already 19th century or prior. That is not the case for Sweden. And it's also, if possible, cause of death information can give us another insight into social inequalities of health. And here again, the same data source has been now linked to cause of death data and looked at different kind of. So we have all-cause mortality, infectious disease mortality, circulatory, respiratory, other cancers, external, and other causes. And not the social inequalities are not, and this is for men ages 30 to, I think it's 60 or 90, maybe 90. So adult men. And the reference category here, it's again a relative risk measure. So we have a reference category, which is the lower skilled. So that, again, the same group. But as we can see that, for example, if we look at all-cause mortality, there are no social gradients in the first two periods. Before 1920s to 1967, but the gradient becomes very evident by the later period. So 69 to 99, higher managers are much lower mortality risk compared to lower skilled, and the gradient, this kind of top from bottom, is even more evident by 2000 for the last period. But we see that not all causes have the same gradients. It's interesting that in the last period, the gradient is evident almost in all the different causes. Whereas, for example, it emerges, it's the other way around for other cancers early on, whereas then it kind of switches around. And yeah, less evident, for example, infectious diseases. And of course, in the later period, infectious diseases are such a rare cause of death. But gives you a new insight into these kind of changing social gradient patterns. Of course, it has quite a, first of all, to be able to look at social gradients in health over such a long time with such detailed data set puts a lot of constraints on your data. So it's not possible in many instances. And I'll bring in now, final bit for the lecture is I'll bring in also the place. So research has also highlighted the importance of understanding the combination of local environment, so place of residence and social status in determining mortality. So for example, this is a study from Alice Reed using the individual level census data from 1911 in England and Wales, and estimating indirect measures of infant mortality rate for different social groups, but in different locations. And what this shows, looking at the different places, is that social class gradients are much stronger in professional and these kind of industrial areas than they are, for example, in agricultural areas, where in agricultural areas, which was the majority of England and Wales at the time, geographically, infant mortality rates were low and there wasn't much difference between different classes. Whereas in professional areas, which are the urban areas, the larger cities, higher social classes, so these higher managerial groups had much lower infant mortality rate throughout the period. And then the other social classes had higher. And similarly, you see similar pattern in industrial areas. And industrial areas in that time period were mostly mining areas. And one of the kind of main takeaways from this paper was that place matters as much as social class in looking at these gradients. And depending on the location, social class differentials might be smaller or larger. So that brings me to really another aspect of looking at health inequalities is looking at the geography of health inequalities. So here is an example of kind of how contemporary public health people would look at health inequalities by different regions. And they would use this measure called index of multiple deprivation. This is measured for England and Wales, England, but I think similar deprivation measures are used also in different countries. And this is really for public health, but also policy making, how to make, to understand health inequalities and how to address them. And this graph here shows the difference between, so the lower, so the number 1 group is the most deprived areas compared to the least deprived, so the kind of gradient in life expectancy. And there's almost over 10-year gap between the least and the most deprived areas. How to estimate these measures of multiple deprivation is that it's like a composite measure. It includes a lot of different indicators. It includes information about income, employment in those areas, about health and deprivation and disability in those areas. It has also information about education, skills training, about crime, housing, services, living environment. So that type of information is all kind of contributing to understanding the deprivation of areas. And we can see that on this graph, the most deprived areas are the darker color. So you get this, in London, very nice pattern, a very historic pattern, really, of west part of London being the least deprived and the East London being the most deprived. It's kind of very, has historical roots in this pattern. But also these mining areas, or I'm saying the northern areas in England and Wales that were the mining areas back in the day are more deprived than many other parts, especially in South England. But I'll come back to this geography a bit more later. So regional differences or regional inequalities in mortality have been are not a new development. They were there already 100 years ago. So from one of my own studies where we studied infant mortality differences from 1870s up to 1911, we used registration subdistrict level data, so this kind of aggregate level data, to study patterns of infant mortality and how they kind of changed over time. So what we saw was that infant mortality was the highest in cities and urban settlements, probably not surprising, especially at a time of high levels of urbanization, but also poor quality living conditions in large urban settlements and overcrowding, and also kind of concentration of poverty in large urban areas of England and Wales. So also what was linked to high levels of infant mortality were some kind of differences in occupational structure of different areas. So for example, you can see in most of these maps, higher levels of infant mortality in this Lancashire, Yorkshire area, in this Durham area, especially visible in the 1896 to 1901. Pretty much all the red areas that highlight up are the old mining districts of England and Wales. And those were also the areas that infant mortality decline was lagging a bit behind, whereas by the south of England again stands out as much more ahead in this process. But if we think about geographical inequalities, so looking at this map, we think there are quite considerable differences. So you could get levels of less than 90 per thousand infant mortality compared to almost, there are places, districts over 200 of infant mortality in England and Wales. The moment we kind of zoom out, we see that the differences, so this is 1910, the differences in England and Wales, or Great Britain in general, were not as large if we think about the differences you observe across European context, especially very high levels of infant mortality in southern Germany, but also southern Europe, and also East Europe, so Eastern Europe and Russia. And the lowest infant mortality rates observed in Sweden and Norway. This is kind of quite a complex patterns of disparities in infant mortality in this context. So there's really not one cause for large regional inequalities, but in a way we can think of it as a composition or like combination of, first of all, structural factors, but also differences in population composition. Here I'm just trying to list some of the factors that can be important depending on your context, depending on time period. So first of all, level of urbanization. So for example, in the past, more rural areas had lower mortality, but of course that there's a shift in the 20th century that actually during the 1930s or so onwards, urban areas tend to have lower mortality, so something to consider. There's a difference in local disease environments and how population density, overcrowding is an important determinant of poor health in that context. There can be also very large differences in inequalities in sanitation and public health investments. The local occupational structure and labor market opportunities that really influence different aspects of demographic makeup of the region or the districts. At a certain point, healthcare provision becomes very important and how that influences health outcomes. And of course, important information about poverty or areas of deprivation that are in a way clusters of poor health. And it's not only about the population composition, it might be also something about the areas themselves. And that brings me to these kind of ideas of the persistence of inequalities in health over time. So this was something that was picked up during COVID pandemic was reported by BBC using one of the maps that we have done for our website on the populationspast.org. They were comparing that COVID mortality rate in 2020-21, the spatial patterns look very similar to child mortality patterns in 1851 in England and Wales. So could it be that places in which people had poor health in the past tend to still have poor health today? And this has been studied also in a few papers. So Ian Gregory's paper is a good use of using deprivation measures and standardized mortality rates. So he uses data from 2001, and which has mortality and deprivation data, and he uses data from 1901 to 1910 for district level mortality data, plus also census indicators. And he uses something, so his deprivation index is a Carstairs index that uses 4 census variables. So it has something about overcrowding, low social class, male unemployment, and households with cars. This is what's used in this deprivation index for 2000s. And in 1900, of course, he doesn't have information about households with cars, but he tries to use as similar measures of deprivation to calculate the index from the census. So he uses overcrowded housing that is available in the English census. He uses social class, again, low social class, and he uses low in unemployment, not low, unemployment. And he interplays the 2000 administrative geography to the 1900 districts. And what he really sees on these graphs is there's a very long-standing relation between deprivation and mortality. So areas which had the relationship is similar. So in 1900, areas with high levels of deprivation had high levels of mortality. And similarly today, the relationship is similar, or 2001. High levels of deprivation have high levels of mortality. And these kind of, if you compare the deprivation indexes, you see also that places that had deprivation, high levels of deprivation in 1900s also have high levels of deprivation in 2001. So kind of long-standing patterns that seem to be holding over time. And not only Ian Gregory's work, but there's also a different approach to the similar question. So there's this very interesting work by Charles Booth from early 20th century. And it's the inquiry into the life and labor of the people in London. And he surveyed the working class life in London. And as you can see, I recommend really going to see that website because it's very cool, early social study. But each street in London is given a kind of like a status measure. So the yellow areas are the upper middle class streets, and the more blue areas are the low class streets that have more population that are lower social class. And in a paper, Doling et al. Use this data. So they have a poverty index calculated using the Booth data from 1896. So we have in London, as I mentioned, the West End is the richest areas, so more white, and the poorest areas are more in the East End, early in 20th century, 20th century. And then they use measures of poverty indexes from 1991 census, which show a very similar pattern, and also a standardized mortality ratio, which again has this west to east pattern. And what they found that at least if you think of central London, a measure of relative poverty and affluence of places over 100 years ago is still a very useful predictor of inequalities in health in 1990s. And it's really the predictive power of the Booth index. It's really a kind of illustration how the nature of different parts of London has remained relatively stable, despite really constant changeover of mortality or the population. And why this social segregation, if we look at the London case, is kept is through the maintenance of kind of differential housing, sorting population across London. And in a way, they take the argument even further, and they're saying, like, really 100 years of policy incentives thinking about health inequalities or social inequalities more broadly have had really no impact in patterns of inequality in London, if you think about how some of these patterns still look pretty much the same. So I'll wrap up on this thought. I think I'm hoping what you take away from this lecture is how in your own work you can think about studying health inequalities, what dimensions of inequality you're interested in, how different types of measurements might suit your research question, but also like there's many ways to measure both inequalities and socioeconomic status. And yeah, I think for the Great Leap project, one of the ideas is also to think about that cause of death patterns can be very good indicators of mechanisms in health inequalities. And I think there's really need to bring those more into our work, thinking about social inequalities in health. But yeah, thanks very much. If you have any questions, more than happy to take questions. Or clarification questions are more than welcome. Yeah, Mark.
Yeah, so thank you for that. That was really interesting. So I have a question. So currently I have a master's student who also is interested in studying the inequalities of malaria throughout Finland. And so we have some data on occupations, but it's very unclean, so to say, and also quite hard to classify. There's no HISCAM scores or anything like that yet. So do you think that there are certain cases where omitting certain social factors like socioeconomic status is okay? Because I had a discussion also with my supervisors about this, that perhaps something like socioeconomic status might not be very important in studying inequalities in like malaria, like such a kind of opportunistic factor that is maybe not necessarily linked to certain socioeconomic status factors.
Yeah, in a way, if you think of malaria, and I assume in like this is more 19th century context or even earlier.
Yeah, so it's 19th century, like 1800, 1850, that half decade.
Yeah. So occupations are complicated, and coding them is slightly, can be a complicated job. I think in most contexts with this kind of more infectious diseases, 19th century context, I think there aren't many examples that there are large social inequalities in health. It's more like thinking about the mechanisms, like would different social classes have opportunities to like different living conditions.
Yeah, exactly. So we also have that, like the lower class, for example, was often servants who were actually living with their kind of like the upper class.
Yeah.
But in that sense, kind of exposure might not be very different between these classes.
Yeah.
And also the upper class often had like living arrangements next to large lakes, kind of the nice spots, so to say. So that also makes maybe the upper class maybe even more susceptible to. So it is definitely something we want to consider.
It would be interesting. It was still interesting. I don't know I know that there's some people in Denmark studying malaria, also Romola in Cambridge. I don't know if they're looking at social inequalities in that very much, but maybe you're in contact with them already.
Yeah, no, I'll write that down. Thank you, at least.
Ura, you have a question.
Hi. Yeah, it's more of a curiosity-driven question. So you saw the infant mortality inequality between the first. Thank you so much for the presentation. I missed to say that. It was great. The infant mortality differences between different generations, like 1960s, 1910s, and all different generations. And I was just wondering, the earlier generations, they survived during the time when there was a large infant mortality. And the later generations, they survived when there was a already shrinking infant mortality. So how do they fare in the later stage of life? What's the mortality differences? How does it compare with between two different generations? I was like very interested in understanding that. Did you understand my question?
Let me try to rephrase it and see if I understood it. So you're saying that if we look at adult mortality in later early, that
Mm,
they
yeah.
have survived earlier phases of high levels of infant mortality. So
Yeah.
they're kind of a selection problem.
Yes.
Yes, I think how you. Of course, there's quite a lot of work showing, especially again with the Swedish data. There's Luciana Quaranta's her own work of these kind of early life conditions and higher years of higher levels of infant mortality, how they might have effects on later survival. I think in general, I think the effect sizes maybe are not that, so the effects on later life mortality are maybe not so large. And in these, if they, let me scroll back. So for example, in this type of approach, if they look at this adult mortality, they use the same longitudinal data set. And I think the model estimation, in a way, because you have both ends, the kind of selection into the model is dealt with that you only look at people surviving until age 30, and then you censor them again up to age 60. So you have like left and right censoring. But yes, interesting thought. I don't know if I have a good answer for that.
And I was just a little curious.
No,
also, there's one more thing that I'm also a little curious because I didn't understand quite well that thing. Is because in the same generation, that is something also we explored during our during the summer course in the university. There is the change in occupation and the social status during the same generation, right?
Mm-hmm.
So you become rich or you can become poor. So and how it develops into the mortality inequality in later phase of the life in the same generation.
So you mean that if they're in the same generation, occupational status changes?
Yeah, occupational and income.
But is it that somebody goes through like social mobility, or is that the same occupation means something different?
No, social mobility.
Yes. So that's difficult. And that's a measurement question. Like, for example, with a lot of the studies that we have, often you have a good measure of people's occupation or status at the time of maybe marriage, but that means in their 30s. Or you have when they have demographic events. So a lot of the Swedish data sets up to 1930s, let's say, you'll have information at time of marriage and then your children. So the man's occupational status will be measured. But that's probably only until your maybe last occupational measure you might have at your 40. But you also have the death register. So what they do in Swedish case, they just use the highest. So if you go through the social mobility, but of course it would be interesting. I think there must be studies looking at like social mobility, people going through social mobility, how that influences their health across life scores. I don't think I can come. I don't know very many examples in the historical context, but there might be, and I'm just not aware of them. But yes, it's something to consider, and when that change happens. So if you become higher social status 5 years before your death, I don't know how much that matters compared to kind of the length of being in the different status.
Thank you.
Welcome. Let's see if I can see the chat. Oh. Okay, do we have any other questions? Should we go and enjoy our Friday evening?
May I add
something?
Yes, sorry to interrupt, but since we got really good question from Uda, it's possible in Norwegian register dataset to check it, and you can have since 1994 till 2023 not in a historical perspective, but in the national register, they keep tracking the occupation and education level. So it might be a very interesting idea for your PhD as well. Project proposals. Thank you.
Yeah, I think also in Sweden that they have the SCDD, and I think from 1800s. But the problem is, like Hannah said, like they only register the highest occupation. Maybe I haven't explored the Norwegian data. Maybe they have occupational.
In Norway, it's yearly registered. So, for example, for that specific year, it is the highest. But through the years, you can follow the individuals. So each year you can also track when it changed and when was the person, how old that person, or what's changing the life. So all the information which you need, but it's not historical, it's contemporary data, but it can be interesting.
Yeah, and you can think of these as like sequences. So like, does it matter which standing, the length of sequence in which standing has a more impact on the later life mortality outcomes or something like that? And very interesting. Good.
Okay, I'll ask one last question then.
Oh, maybe I can answer one as well. Let's try.
Yeah. So the thing is, the household status, how the household is, how they have the sanitation facility or anything, and the occupational status and income status, they both are entangled with each other, right? If you have high income, that means that you have a higher occupation and have a good living situation. So how do you control for all these things? Aren't they overlapping in many ways?
They could be highly correlated. So then you kind of, in a quantitative setting, you need to test that. And if they are highly correlated, you can't include them all. So if you see that, for example, income, but they don't have to. So that's, if you have a large enough sample, you might still have variation by the occupational status and variation in incomes. In a historical setting, again, it's rare anyway to get income data, so I wouldn't know. But there might be like, yeah, there might be like a high correlation that in a historical setting, for example, if I think back of some of the data, so for example, in that Estonia study where we had in the census, we had both occupational data and we had educational data. But the educational data was like, people who were higher educated were very rare, and they tended to be all in the same, like they were nobility or had certain occupational standing. So these two variables were very highly correlated. So often in the models, it was difficult to use them at the same time. So yeah, it is a concern. Whereas the moment you have more variation in those variables, it becomes less, so they're not so correlated. If you have variation in educational, so there's educational expansion, more variation in people's educational levels, and you have also more occupations within your sample, it's less likely that they're so correlated. And they measure slightly different things. So as this kind of the more contemporary Finland study was showing.